management. The next concern is after doing a good vitrectomy and removing the cortex. The next aspect is IOL placement in these eyes. So when considering IOL placement, this flow diagram gives an approximate idea. So if one has an intact rhexis and there's a small PC dent, one can consider placing the lens in the bag if someone is comfortable doing it. However, if the intact rhexis but the PCR is large, or if you have a small PC dent but a can opener, then you have to think of a sulcus placed IOL. If it's a very large dent and there's no anti-capsule support as well, then you have to look for alternate techniques like anti-chamber, iris suture or steel fixated IOLs. For capsular placement, I would always recommend using a single piece foldable lens because that is most capsular friendly. It won't extend your lens. And for sulcus placement, a 3-piece foldable is always recommended. Foldable or a rigid lens. So before placing the lens, you will have to clear the vitreous and the lens matter. You want to be able to see where the dent is. If you want to be able to see if any cortex is remaining. So all this you should clear. So hooks are very useful. Most of these cases, people will come down, especially in the PC dent. So almost in a routine phaco, even if you don't use a hook, you can still continue. You can always do a chop technique, have it in the center. But in a dent, you'd want to assess before you place the lens. Either use an iris hook or a wide hook and retract the iris and then place it. And then you would assess the support of the capsule, where is it, and then decide on what kind of lens you would want to place. So to improve visibility, like I said, use these iris hooks, and this will actually cause more space in the anterior chamber. So it will lift the iris, cause a pseudo deepening of the posterior chamber. So this will lift it. And then you can place your 3-piece IOL. So I would normally use a sensor lens because the anterior edge is rounded, and ensure that the leading haptic is flexed over the optic and the leading haptic goes into the sulcus. Since you can visualize the rhexis rim, that will be possible. The wound also has to be large enough. We tend to use larger cartridges for these 3-piece lenses. So based on what lens you're using, ensure you're taking your lens inside and then release the haptic. Don't do a wound assisted. And the trailing haptic can either be dialed in, or you can use your injector itself to place it in the sulcus. So these hooks can be retained till the end and then remove it and then wash the viscoelastic. Another option is if you don't want to use hooks, a pupil is slightly large, like 6 millimeters, use this Coughlins hook. So when you're injecting, again lift the iris, retract, see where the anti-capsule rim is, and then take your cartridge close to the rim and then ensure your leading haptic goes in the sulcus. This is the most common error. Everything goes well, we think we place it in the sulcus, but it goes in the bag and then you have a decentration or dislocation. Trailing haptic also retracted. So this, you have this small Coughlins hook which even go through 1 millimeter, they're very comfortable to use. So in a non-dominant hand, using it will be advantageous, and always do an optic capture wherever possible. Now this is possible if you're using a plunger. If you're using a dialer and if you're using 2 hands, then you can't do this. So their iris hook may be better, or you'll have to have your assistant screw the injector for you as you're placing, which may not be safe in these cases. You won't have as much control. So using an iris hook is better there, or use a plunger and use a Coughlins hook in the non-dominant hand. So this is a case where the surgeon has assumed that the lens was in the bag, but was in the sulcus, but has gone into the bag. So this is what can happen. The lens can decenter. This is exactly what we want to avoid. Now this lens you can place in the sulcus because the haptics are PMMA. Otherwise one will have to explant. If it's a single piece lens and you want to place it in sulcus, you'll have to explant and then place a 3-piece IOL in the sulcus. So here again the iris is retracted in the non-dominant hand. Use a Sinskey hook and then dial it into the sulcus. Now placing a single piece in sulcus, one, it can cause a decentration. It does not sit well. More importantly, a lot of pigment dispersion can happen. The patient has chronic pain and inflammation. So that is why we would not recommend a single piece foldable, especially the Acrysof and the other hydrophobic lenses in the sulcus. Now this is a patient who had a posterior polar cataract, and some of these situations you can place the lens in the bag. In a posterior polar, obviously one has to ensure you're very controlled. So there's a rent, as you can see there. Before the aspiration probe is removed, this coat is used to plug the rent. So the goal here is to retain this rent to this size. We don't want to enlarge it. viscoelastic is then, it's completely filled with visco, and then the lens is placed. Now a single piece lens, again you have to take it into the, ensure the leading haptic, the optic haptic junction goes in the back. And this is most capsular friendly because these haptics are very soft and they can be flexed over the optic and released. You don't have to dial the lens. If you dial, then this rent can open up. So put enough visco in the bag, open up the bag well distended, and then you will ensure that both the junctions are tucked under the rexus margin and then released in the bag. If you have a doubt, better to go in for a 3-piece. And also ensure that the haptics are stable. If you're having a rent which is large and you're placing a lens in the bag, both the haptics have to be stabilized well. So it has to be over the area where the PC is intact. Now this is more linear and central, so it doesn't matter, but otherwise you'll have to be aware of it. This is a patient who has a PC rent. Half of the nucleus is still there, but this is a soft cataract. So in terms of how to approach a patient step by step, now I'm going for a phaco here, one because the nucleus is soft, second there is no vitreous yet in the anterior chamber. Otherwise I would have thought of converting. If there was vitreous, I would do vitrectomy first, and conversion may be an option. So very gentle phaco, very slow controlled phacoemulsification is important. Try to have the phaco tip away from the rent as much as possible. Anytime you find vitreous is there, you'll have to stop and take care of it. And the lens matter and the cortex matter is aspirated very gently. So the rent is somewhere on the opposite side and the tip is away from it. The epinucleus is also removed and then the cortex is removed. So once you remove the epinucleus, the cortex aspiration, as Anand showed, bimanual works very well, and try to remove the cortex away from the rent area first, because there the chance of having vitreous loss is minimized. And then go to the area where there is the rent towards the end. So I'm doing a vitrectomy before lens placement. I try to have the cutter facing the vitreous. When you don't want to have it facing down and cut the whatever PC support you have, but having the cutter facing it will help to cut it and will make the vitreous go back home, push it down. And like I said earlier, I would like to extend the incision here so I can comfortably go in, no wound-assisted implantation. Place the IOL, in this case in the bag, away from the area of rent. So I kind of rotate it so that the haptics are away from the area of the rent. That is very important. We don't want to, if we hit it at the area of the rent, then this will extend uncontrollably. And finally, because the wound is extended, I am going in for the Simcoe aspiration. I'd like to use pilocarpine in most cases because that will ensure there is no vitreous and the IOL is sitting well in the back as well. Now this is a large PC rent, and this patient, so stepwise approach if you want to place a lens in the bag. So first thing obviously is to take care of the vitreous, do a bimanual. Now here it's a large rent, so the cutter can even face down, it's absolutely safe. And once it is, the vitreous is removed, the rent is sealed with viscoelastic. Hooks are being used mainly because I want to enlarge the anterior rexus margin so that there is adequate space to place the lens in the bag. So that is why there should be enough space between the anticapsule rim and the posterior capsule. So the rexus is first enlarged. This is a hydrophilic IOL, the Oroflex IOL on the Rayner design. So here again, it is being placed such that the haptics are stabilized. So using two instruments, you can dial the IOL away from the area of the rupture. And finally, this cortex is aspirated and the hooks are removed. In some situations where you don't have adequate support, one can consider other options. So I'm just going to show our technique of iris fixation. I do more of iris fixation than stereal fixation. So I do two techniques. The first one is in this patient where the nucleus is grossly subluxated and the whole nucleus is prolapsed in toto into the anterior chamber, and a vectus is used. I'm doing an SICS here, using a vectus without any irrigation, just removing the nucleus in toto, the lens in toto. Following this, a vitrectomy is done, and the iris fixation technique can be done mainly in patients whose iris is intact or almost intact. In those cases, it can be done. So once vitrectomy is done and the pupil is constricted, before the lens is placed, I place 2 bites, so using tenoproline on long suture needles here. So I place these bites more towards the periphery, mid-periphery or periphery, and on opposite side on the iris. And using the same needle, I rotate it and take the 2 bites, and the sutures are then brought out through the main tunnel. So the suture from below the iris is brought out using a Coughlins hook, received from the McPherson's and brought out through the main tunnel. And the second bite, also the suture is retracted in a similar fashion. So it's retracted using McPherson's and brought out through the main. So we basically have 2 loops, 2 bites on the iris. The 2 loops are brought out. The loop on the right is then twirled at least twice. I don't like to tie the knot here because it may cause an eccentric fixation of the lens. I just twirl it twice to ensure that the loop stays on the haptic. And as it's being placed in sulcus, I would pull on the suture outside so that it does not slip from beyond the edge of the haptic. So just gentle tuck, and you will find that the IOL is suspended from these sutures and placed in the sulcus. Through the side port, the suture ends are retracted. So this is a modification of the McCannell's technique. I do this technique, I don't tie the knots in the anterior chamber itself, because when I do it, I find that the iris may get more crushed and it may cause more pupillary peaking. So I rather prefer to bring it out through the side port, which is also much simpler to do. So both the suture ends are brought out through the side port, and then a couple of knots are thrown in such that the knot thus lies on the iris surface. So because you have that space between the iris and the side port, so once it's pushed in, you'll find that the loop around the haptic and iris is not too tight. The second haptic is also fixed in a similar fashion. So this is an anterior segment technique, and even if it's a tenoproline, we don't have an issue with degradation in this technique, as we would see with the scleral fixated lenses. This is another technique where the IOL is placed first for an iris suture. This is the last video. This is a hydrophilic lens, and as you can see, the complete bag contraction is there. Patient with the retinitis pigmentosa. IOL is cut and removed through a 2.8 millimeter incision. So here I'm placing a regular 3-piece foldable IOL. So this lens is placed in the anterior chamber. And before fixating it, the leading haptic alone is placed in the sulcus, supported from below with a spatula. So only the haptic. So the goal here is to get a pupillary capture. And for that, the trailing haptic alone I flex below the iris. The most important thing is I support the optic from the spatula from the anterior chamber. So this is where the capturing happens. And once the capturing happens, there's no issue of IOL dislocation, etc. And then also the haptics become prominent. So you can see where it is. And then you can fixate on both ends, and finally you can tie the knots such that the IOL is well stabilized. So this is a technique which I'm doing more recent. The earlier technique is only possible with rigid lenses, whereas this you could do for foldable or rigid IOLs as well. So in conclusion, it's important to recognize the rent as early as possible and ensure you also have the right kind of IOL based on the amount of PC support you have. Thank you.
We should thank HARIPRIYA also, no? So I will thank HARIPRIYA for this wonderful talk. And this, the last technique you saw, the iris, suturing on the iris. Before you make the knot on the iris, the optic was pushed behind the pupil. So that will prevent this cat's eye, the iris being stretched and you getting a cat's eye kind of. So if the optic is on top of the iris and if you knot it, then if you push it down, the iris will get bunched up there and you will get a peaking of the pupil and
So we can take any questions from the audience if you have any questions. Yes, iris claw lenses work very well too. I just did not show it, but they work very well. So the iris claw, I think it seems to work better in secondary situations, but primary also. But one has to be sure that the tissue actually is well enclaved, because there could be an issue with you're not sure if it's being actually enclaved, which could lead to decentration, etc. But that iris claw technique also works well. But it also you have to have the inventory and have that, and the wound also has to be enlarged to be able to place it. Yes. This is a long curved needle, but you can also use a straight needle and just bend it in the tip towards the end to help you take a bite. Tenzo, they also have a curved model. I don't have the model right here, but they also have the same 10-0 on a curved needle. Regular curved needle. Long curve, not a small curve, but a long curved needle. Yes. This is also, I think, Alcon, Ethicon, all of them also have it. Yeah.
Technis also has the same rounded anterior. Technis also. But
Yeah. Yes, they also have a 3-piece model, which is also anti-surface is rounded. You can use that also. Sensor is not available.
Now it is very difficult.
Difficult
Sensors are.
Oh, okay,
So
because we are using this.
if your access is okay, then you can do reverse optic capture with a hydrophobic lens. It also works very well. If your access is 5 millimeter or less, you can do reverse optic capture where you are placing all your haptics in the bag or inside the bag and just nudge it out the optic part over
I mean
the
haptic in the sulcus and the optic in the bag.
haptic in the bag and optic in the optic above the rexus margin.
no, that is question is different. That if you have a rounded edge and if you
Okay.
have the optic in under the iris, you will get iris chafing. So that's why we want to go get it under the anterior rexus margin.
No, I am telling
But-
when 3-piece lenses are not available.
Yeah, single piece lenses is what he is telling. You can
Right.
place it into the bag where the area of support is there, and you can stabilize the optic by reverse optic capture on the anterior.
Which actually is not very
Not
easy to do.
agreed, yeah.
Not very easy to do because it goes back with a single piece.
So if your rexus is small,
Rexus has to be really small.
5
It has to be
mm it is
five, less
okay.
than 5.
Yeah, it
always.
should be very small to capture it. Otherwise, when you're forming the AC and stuff, the optic can actually go down. So you'll have to, if your haptics are bulky, this may be difficult. So it depends on lens, what variety you're using.
See, one more thing about the post-op management. See, we'll be happy after placing so much of viscoat and visco inside the anterior chamber and then not taking out any of the visco underneath the IOL. So, lot of viscoat, especially HPMC, if we are put into the area of vitreous, it mixes up with the vitreous and causes lot of glaucoma and uveitis. So, once you see a PC rent, throw away your HPMC. Use only sodium hyaluronate or a combination of sodium hyaluronate and the viscoat or the oro coat. So, and aspirate underneath this one by irrigating. If you can irrigate, it will take out a lot of visco from underneath and treat patients as though they are going to get an IOP spike and give them Diamox and anti-glaucoma medication for at least a week because many of them come back with raised IOPs.
triamcinolone also should be used judiciously. Like you have to dilate it. Sometime diluted should be used. Sometime it goes lot of triamcinolone goes inside the vitreous and causes lot of IOP spike afterwards. And one more essential thing is that after your surgery, post-op, you should see the retina fundus because picture में अभी बाकी है मेरे दोस्त this happens. And the last case which I showed, there was no vitreous prolapse, but third day when we saw there was a rent because it was a high myopic case. There was a retinal, no, there was operculum because of a small operculum just above that tear, and we had to do VR surgery. So very essential these points.
Do you recommend putting an infusion cannula while managing these type of cases? 23 gauge infusion cannula which can be left unsutured.
We don't recommend. If you're using viscoelastic, I think there should be no issue. But if you're doing, are you meaning for your pars plana?
No, I mean if we put 23 gauge infusion cannula.
For which step would you want to that?
After we have a vitreous prolapse, sometimes into the AC, and when we want to do a pars plana vitrectomy.
For pars plana, it may make sense.
I mean
But otherwise, if you're doing it
pars
with,
plana anterior vitrectomy from pars plana route.
yeah, right.
So, what you actually mean is you have a constant irrigation place somewhere and use it whenever required so that your other hand is always free and you
Always
have
free
irrigation always in. It's a good idea actually to have irrigation always in, but when it's required, we can always use our left hand irrigation as she was mentioning for the vitrectomy, and usually for the pars plana also irrigation goes from the limbus. So, we can always use the limbal irrigation, but always well taken. You can always have an ACM put in and use it whenever required and use the other hands well.
Yeah. Also
Normally you
use
do
it,
not-
use
normally in
it
every-
judicially because sometimes that itself will cause more vitreous. If you're having too much of fluid, so you'll have to use it on and off, like Minu was saying. When
Yes,
required,
on
you
and
switch
off.
it on. Otherwise, continuous irrigation also may not be a good. So visco normally is safe, so you would do the vitrectomy and seal with viscoat, and that will make it much quieter and safer for your other maneuvers as well.
Thank you, thank you.
Yeah. So the other thing is, endophthalmitis is about 7 to 10 times higher in these eyes with PC rent. So you'll have to close your wounds very well, and also we would recommend using intracameral antibiotics as well, and especially in eyes with PC rent, because the risk of endophthalmitis is very high. And not all these patients have high IOP. So on post-op day 1, you'll have to see, especially if you've extended the wound, there's more maneuvering and all that, you can have an opposite issue of hypotony as well, which again increases the risk of endophthalmitis. So don't automatically give them anti-glaucoma medications. See them on a couple of hours later. See them on first post-op day, how the IOP is, how the cornea is, and then if required, if it's high, then treat accordingly. If it's low, you may have to patch the eye or take it up for the wound suturing or closure. That probably would also. You have to manage accordingly as well.
In such
And
cases,
have 3-piece IOLs always as backup in all your cases. 3-piece IOLs as backup for all your cases. I have it for all my cases now. 3-piece IOL is backup.
part of contingency kit.
Yes.
Yes, please. No, not to a big deal. So pilocarpine is only to ensure that there is no vitreous tags, there's no peaking. That is the only reason, but it doesn't help in controlling IOP. So we use it. Yep. So we use intracameral moxifloxacin for all our surgeries. Intracameral.
Yeah, phenocaine.
Oh, phenocaine. Yeah, phenocaine is yes.
Yeah. If it dilates well and
After
good.
the PC tear.
If it is a PCT, yes. But the only thing is you should do it when there's no viscoelastic. So you have to aspirate otherwise it doesn't work. So aspirate the visco, and then otherwise it works very minimally. If you can, then do a vitrectomy and then phenocaine and then put visco. That should probably be useful. It's the same concentration. A little more is also good. I mean, we have some concerns about using too much will cause TAS or corneal decompensation. We actually haven't seen any such thing. So I wouldn't recommend a lot more, but at least about 50% more dosage, especially if you've done an extensive vitrectomy and it's absolutely fine to use a little more.
You're asking about the dose or the concentration?
We have not seen anything like that, no. No,
all
we,
ca-
yeah.
all cases you.
Sometimes I have seen people did iris claw and patient came with
Iris claw 100%. Iris claw 100%. But
Iris law you have to place.
Circle placement always need not. You're not expecting not too much of fibrin and pupillary occlusion, then you don't have.
After good vitrectomy, there is, I think, no need now.
You have to do a PI, yes.
Yes.
100%.
No, it is always essential to do.
It's a small optic, and it's too close to the iris, so there's a high chance of it causing a pupillary block. So you have to do a PI for iris claw. Not all of them, some cases you may get away. It doesn't mean, but there's a high chance of a pupillary block, so you will have to do a PI iris claw. So thank you all for your patient listening and coming to the course, and thank you all to the faculty for your wonderful